Hi everyone, welcome to the second series of LA Appendage closure. It's a very it's a structured course, and today we are going to have a lot of discussion about different devices, imaging, and how to handle a difficult device. So with me today is from the two of our masterminds who have a lot of experience with this device and who can guide us. They will also be taking most of the questions. One is Dr. Ramesh Daggubati, who is my good friend, and thank you, Dr. Ramesh, for accepting the invitation. And he's been a great inspiration for all of us in India, so he doesn't require any further introduction. I also welcome Dr. Carsten Skurk, Head of Cardiology, University of Charlie Berlin in Berlin. Welcome, Dr. Carsten. Thank you for accepting the invitation. We also have great, experts from India. Dr. Hazra, my good friend, is already joined in. Dr. Ajay Swamy would be joining soon, and Dr. Abhishek Abhishek from Ahmedabad is also he's joined. So we would be discussing about LAA stepwise, but we would be, all of us would be happy if you could ask your questions, and we want it to be more interactive. This is not a usual standard presentation. We want you to come up with your problems, what you face, which could be from starting from convincing a patient, identifying the right patient, and also how to do it. So without wasting much time, I think I will start my talk first. And that would be on LAA. And today what we have done is I've chosen to discuss a little more about the WATCHMAN device, the step-by-step WATCHMAN device, the steps. So just give me a sec to get it back. Yeah.
Sorry to disturb you, Dr. Ranjan. Hi, this is Dr. Ajay.
Hello, Dr. Ajay. Thank you for joining us.
Hello, Dr. Ramesh. Nice seeing you.
Yeah.
Nice seeing you, Dr. J. Swamy, and Dr. Hazra.
Yes. Thank you. I hope my slide is
caught
visible.
Up with a small emergency, so just joining a couple of minutes late. So do pardon me.
Yeah, Dr. Ajay, are you able to see my slide? Yeah.
Yes, sir.
Okay. Thank you, Satya. So we are going to, this is the first talk where I'm going to discuss step by step on LA in general, and this time WATCHMAN in a little more specific. And then we are going to have question answers, any questions, and then we will go to next two talks. Take a small, we are going to have a little more questions, and Dr. Ajay is going to show his case after that. So we all know that left atrial appendage is an important structure, especially in patients with AF, because more than 90% of the clot actually comes from this area. And that is something which is troubling. And to prevent it, we what is advised is an anticoagulation guideline, which has been given for which is very effective. And now we do have lots of newer drugs which are available, and they do have a lot of advantages. But then when you have to give a therapy for life, there is also people tend to bleed. So it's like there is, even with the best of the drugs, up to 1/3 of the patient, 1/4 to 1/3 don't take it for reasons other than finances. That means they are not able to tolerate it, and there's also 2% risk of bleed. There's a distinct group of patients who have not been studied in any of the trials, and that is people who have already bled. There is no trial in this group. In this group, it is believed that LA is the only option, but to be honest, there's no trial for this group. What about people with CKD who cannot take newer anticoagulants and they need to undergo dialysis, liver disease patients who have ulcers, who have bled? So there's a huge subgroup of patients who are not suitable for blood thinners of any sort, and some of them at least need LA as an alternative. But world over, indication has varied. 90% of the people world over actually receive this therapy when they have clear-cut contraindication for oral anticoagulation. Only 1% world over receive as an alternative. But I think US, where the approval itself was as an alternative to people who cannot or who do not want to take anticoagulation. We will obviously ask these questions to Dr. Ramesh to understand the practice in US and practice in Europe, and we'll have a discussion with our colleagues here. Now, what is strange about LA is, unlike a coronary angioplasty, you could decide, I will just do a simple type A because angio is already done and you think you're good at doing type A or type B, but you would avoid a CTO for some time. Here you can't do that because most of the time, the anatomy is very varied. Usually people give different names, probably depending on what food they like or what they see that day, but it's not that simple. There's lots of individual variation. There could be early lobes, there could be delayed lobes, some could have bends, making it a chicken wing or reverse chicken wing, and these are the familiar anatomy which is described. But you can't choose an anatomy. Most of the time, once you choose a patient, the anatomy is already pre-existing. You might think it looks like something else, but on table you do find a different anatomy than what you expect. So it's very important for us to learn to deliver the device in most of these anatomies. So that becomes that's something that means you have to have sufficient knowledge even when you are just starting these procedures. So that's something which we need to know. But fortunately enough, if you look at the trials and look at the experience of people now, whatever device you have in your shelf, you are still able to close 98.5% of left atrial appendage. That's good, because when the PROTECT trial was done, that number was 87.5, and with PREVAIL it was 95.5. But with WATCHMAN registry now, we know that number is 98.5. That means in today's era, you don't need to have too many devices in shelf. Whichever device you are comfortable, whichever device you are happy, you could do that. Today also we are going to have discussion about multiple different devices, but my advice is you could choose one device and then maybe master the technique and slowly shift to the different device. So whatever device, it doesn't matter. And so now I'm going to take you through a case, and then slowly we will see how to do it. It's not going to be an elaborate lecture. I would want it to be more of a discussion. So this was a 69-year-old gentleman who had AF with a history of bleed. This patient also had undergone TAVI, and the TAVI was done in Singapore around 5 years prior. And then he had fair LV, diabetic, hypertensive, was a post-renal transplant, had surgery for basal cell carcinoma of dorsum. So too many medical conditions. And then what he had was, whenever he took anything, whether it was a Novak or this, he would get patches of ecchymosis on his leg, and he already had a his leg had a osteomyelitis, so he was really worried about this complication, and plus he had history of bleed. So he flew in from one more city to get the procedure done. So I'm going to describe this procedure. What's very important is it's just the venous puncture. You don't need an arterial puncture here. This procedure is a combination of two procedures in simple words. One is the septal puncture, which what we Indian physicians are very familiar for BMV, and second is the left the device closure, which is like an ASD device. But when you do a septal puncture, please relearn it. You would have done thousands of BMVs, but in this case, you're going to do it little different. That means there is some learning involved, and it's very important for us to follow this learning. I think the last meet, this one which we had decided that this time we are going to go through the basic stepwise understanding what we should do. Now, before that, let's understand how do you measure LA. So this is something which you have need to do. Most of our patients, we don't do a pre-transesophageal echo. I do the transesophageal echo on table before I do the venous puncture, because if I find a thrombus, I'm going to stop there. But unless if there is no thrombus, whatever the anatomy, most of the time we will go ahead and close. We don't do a a CT scan for any of our patient, because the size is very dynamic. It depends on the hydration status, and it's something which is dynamic. So you look at the left atrial appendage. Now this appendage has to be profiled. So this is a two-person job. That means you need to have an echocardiographer or a sonologist or one more cardiologist who is completely aligned with you. That means you need to have a team of doctors. It's not a one-person thing. So when you measure appendage for WATCHMAN, that is what we are going to discuss, and Dr. Ramesh will take it from me later and add some extra points here. See, all appendage have two, they have two parts. One is the neck, second is the body. So there are devices which are put on neck, which will include ACP, amulet, or lamprey. And there are devices which are body specific. So the WATCHMAN has been typically been a body specific device. In a body specific device, the most important structure will be a circumflex. In all of them, the circumflex becomes the most important. So draw a parallel line to circumflex as if you're closing the appendage. So in this case, you would draw a parallel line here, and you would also measure a depth, because WATCHMAN device, the depth becomes important. So you measure it at 0, 45, 90, and 135. So it's 135 sometimes becomes very, very tricky. So your image, the sonologist or a cardiologist who does imaging should be extremely good. I'm very lucky that we have a cardiologist who is trained and who is very keen on doing this. So the procedure becomes very easy with that. So you do a measurement. So imagine you have measured it in all this, and you are also measured the depth. Now, for sake of argument, let's take that depth as 19. So the maximum depth which I find in any of this is 19. So WATCHMAN comes as 21, 24, 27, 31, and 34. It comes in these sizes. Now, so if I get 19, the typical rule is add 4, that becomes 23, and go for the next size. That means you could choose either 24 or 27. So what I typically do is if the depth is enough, I would go for 27, because over compression of WATCHMAN is okay. If the depth is enough, it doesn't produce problem. It actually it makes it safer, and it also keeps enough, the peri-device leak is less. But if I'm compelled, if I feel that depth is not too great, I may have to go too deep. In the same case, I would take 24. And also if I find it to be very asymmetrical, for example, it was 17, 19, 16, and 19 being the highest, then again, I wouldn't oversize. I would take a device of 24. So it's a very oval shape of appendage, which can be easily picked in 3D echo, or can also be picked with the 2D, in which case I wouldn't upsize too much. I would take a 24, because the least is being 16. But if all were 19, 19, 19, that means almost a circular appendage, I would actually oversize to 27. So general rule, enough depth with WATCHMAN. Make sure you measure it right. Enough depth for WATCHMAN. Always take a bigger size. Don't take a smaller size. This is not true for other devices. Too big, any other device will actually be pushed out, whereas too small, WATCHMAN will be pushed out. So when you do WATCHMAN, your mind and your thinking has to be a little different from what you do. Now, next and the most important step is the septal puncture. So you look at the image which is played in your this one. So what we need to do, the septal puncture has to be posterior-inferior, because you're going to an anterior, left anterior structure. So it has to be posterior-inferior. Now, to go post-inferior, you need bicable view. So that's what is shown in this picture. So you need a bicable view, and you need to go into the lower part. You need to go towards IVC. But preferably, you have to still be in the soft area. You can be in the soft area, and you can be in the lower part of that soft area. You don't have to go to a place where the tissue is very hard, because that makes further things very difficult. So go to the lowermost area and produce the tenting. By tenting, what you mean is, when you press it, you are actually able to see it with the tent. So it's a very precise puncture done in AP view under echo guidance. After that, you ask your echocardiographer to go to from the bicable, you go to iotic view. Once if you are biplane, both can play. simultaneously. Once you are in the bicaval view, at that time things, you want to be away from aorta. So to do that, what you need to do is rotate your needle clockwise. Clockwise takes it away from aorta. So you have checked in bicaval view, you were towards IVC, you have checked in aortic view, and you are away from aorta. You are inferior in bicaval, you are posterior in this. Now this is something which we have to learn, and it's very important you do under transesophageal guidance, because once you master it, it's easy to do so many other procedures. There are mitral valvular procedures which you are going to do in future. There are mitral clip, the valves, and so many procedures. So we need to learn this. The septal puncture position varies in all these procedures, but what doesn't vary is the technique. In the sense, once you understand where to puncture, it works. Now there are times your catheter slips when you do that. If you can puncture it easy, it's okay. There are times when it slips. What you could do when it slips is, again, obviously reposition. You could take opposite end of 014 wire, the hard end of 014 wire, just puncture the septum, then put the soft end of 014 or any of your coronary wire, and on that you could push the whole system in. Or what you could also do is use a cautery and touch it to the broken barrow needle. So by doing any of these techniques, you will enter LA. Once you enter LA, now you're in the septal puncture step. So it's very simple, like any other. You have, what you have is a sheath, a dilator and a sheath. Now your sheath in LA. Once the sheath is in LA, you're giving the heparin, half the heparin is given when you do venous puncture. The rest of the heparin is already given at this point, and you black bleed the system and measure the pressure. If the pressure is above 10, it's okay, because it's very well hydrated. If it is not above 10, this is the time to hydrate, because LA it's a dynamic structure, it's a pressure sensitive structure, and it could get altered slightly if you don't measure, if you measure it when it is actually underfilled. Once you do that, what you actually do is, this is to show how the appendage looks in different views. So you see the trabeculated part of appendage, you see the mouth, you also see it in different views. What's very important is, if you're measuring, this is the point where you measure, and you measure the depth. You do the same thing in the other views. The maximum size, upsize by 4, maybe take the next size if it is comfortable. What you do now is this. You could see the TAVI valve already in this patient, and the sheath is in. At this point, what you do is, now that you are in LA, what you should ideally do is pass a wire inside the sheath. You should take a MPA or RPA to make the procedure safe. You could take it to the left upper pulmonary vein. Exchange the sheath in left upper pulmonary vein as much as possible. This step is not a must. It is possible for us to exchange things in appendage, but if you are a beginner, if you are learning to do it, my advice is, don't try it. Exchange it in the upper pulmonary vein. Now that you have exchanged in upper pulmonary vein, you take the WATCHMAN specific sheath, which is a 14 French sheath, and you take it now to the left upper pulmonary vein. Once you have done that, the dilator comes out, you de-air the system. So now you have a WATCHMAN sheath which looks something like this, but in the left upper pulmonary vein. At this point, take a pigtail and advance the pigtail beyond the WATCHMAN sheath. So you have a WATCHMAN sheath and pigtail in left upper pulmonary vein. The whole system could be withdrawn down, and you could pass the pigtail. Never go inside appendage on a bare sheath, because these sheaths are a little harder. So dilator, sheath, these are not the things which you want to be moving inside the left atrial appendage. So what could be best is a pigtail, because pigtail is soft and pigtail is practically atraumatic to a thin structure. So take a pigtail on the device and take the whole system into left atrial appendage. Once you do that, anti-clockwise the pigtail as much as possible, and make sure you're actually on the distal most part of the uppermost part of left atrial appendage. This is very crucial for a WATCHMAN device to make sure you're actually in the uppermost part of the left atrial, the distal most uppermost part of the device, and you can see it clearly. Here all the device is out. This is the point you want to be there. So you're on the uppermost part, you're on your sheath, the WATCHMAN sheath, which has 3 markers, and you have a pigtail top. At this point, you could take a injector and inject into the appendage, and you will get a beautiful image of appendage. You don't have to measure it. The best view for a WATCHMAN is caudal. Measurement is not needed, but you get a fair idea. And based on the sheath has markers, the first marker implicating 21 device, the second marker implicating 27, and the third marker implicating 33. So based on that, you have a fair idea. You need this size of the device, and this is the place where it is likely to land. Once you have chosen your device, make sure the device and the sheath is in line. So you're going to take both of them in and make sure you get the, you get a click there when you connect both of them. And at this point, the device marker and this, what you can see in the image, your sheath is already in, the device marker and this both match. And beyond that, the device marker goes beyond. That's what happens. See here in this, it matches. And once you press further, it goes beyond. Now you're on distal most and anterior most lobe of appendage. You confirm the position both in echo and fluoro. And at this point, what you need to do is you cannot push the system beyond. That is something which you should understand. You're almost completely there. Any push here is going to produce a pericardial effusion. So anti-clockwise the system as much as possible. Maintain the anti-clockwise. 2 words we should remember: clockwise for septal puncture, anti-clockwise to out during the device delivery. So it has to be anti-clockwise, because device has a tendency to fall back into left atrial appendage and align itself in a funny way. So to align it properly, we need to be in the topmost, outermost lobe, and complete antiplos is needed. At this point, what we do is we start withdrawing the device. This is typical unsheathing, like what we do in a ASD. Now both sheaths which are there, they are acting like one system, and we start withdrawing. So you can see here that we have withdrawn the device as much as possible, maintaining the anti-clockwise position. Once you do that, you see that the device slowly expands. Be very slow, maintain the anti-clockwise, and keep withdrawing. As you withdraw, you realize that your device is now opening up. It has its own hooks. It's going to take its time, slowly open and hold appendage. And as you see here on this, the slow anti-clockwise and withdrawal releases the device and makes sure it catches the appendage. Once you do that, this is how it looks. So then you need to do a pass test. Once you are fine, your device is not too in, it's in a comfortable position, you do what is called as a pass test. P for position, A for anchoring. Position is where it is already there. Anchoring means you try, give a slight pull and see that it is fine. That is when you think it is anchored. Then size. You have taken, say, a 27 device. Now you need to measure from the point, the maximum width of the device. That has to be compressed from 8 to 20%. Little more compression is better, not worse. And then you should look for the leak, any leak, peri-device leak. Today's time of appendage closure, we always want 0 leak. Although trials accepted up to 5 millimeter leak, 3 millimeter leak is still okay. We are talking about the peri device. If you oversize the device adequately and position it right, you should be having a zero leak at this. The compression should look beautiful, and if you are happy with all the position which is there, this is the anchoring test which we are showing. Anchoring is fine. We are doing an echo now, showing that there is no peri-device leak, it is fine, and then you release the device, and here you realize that the device has landed exactly where we want it to land. It centralizes itself, it adjusts itself in such a way that the whole appendage is closed, and when it's endothelialized, this area is going to be excluded from circulation, and you are going to have a beautiful exclusion, and it will do its job. Now you are testing it, in this we can see that the same thing in different positions, and we are trying to do a tuck test. We are trying to do the size. To measure the size, it's very important to see at this point. And then the compression, the good compression is already seen. So look for all this. Do not be hurry in any of these steps, and make sure your device is positioned very well. Now, like any other procedure, the complications are definitely possible. The most common, this is a general complication. The most common is pericardial effusion. Be very gentle with left atrial appendage. It's a very thin structure, no too much movement, especially in devices like WATCHMAN. You have to be much more careful. The sheath should not be going in and out without a pigtail. If you think you need to reposition the sheath, feel free to retake the pigtail. Make it go to the topmost loop. I sometimes use a Amplanzer super wire inside the pigtail, not allowing it to come out, to give me that extra position to take the sheath inside, anti-clockwise as much as possible. Pull the pigtail back and then introduce your sheath. Make sure there is no air in the system anywhere, and look for this. Luckily, the embolization is not that common, and WATCHMAN you can capture if you need. You might need a high, but embolization is not that common. It's just 1 in 200 or even less than that. Your puncture is just venous puncture, and most of the time we close it with the figure of 8 stitch so that there is no hematoma, and you could anticoagulate to a large extent. It's a combination. Again, I want to stress this fact that it's 2 persons' job. You need to have a good echocardiographer who can actually help you. I always thank Dr. Kavya, who is our pediatric cardiologist, who helps us in imaging these cases very well. So I think with this, I'm going to stop my talk. And we could have some discussion. If there is any question, we could discuss. Any comments by any of the panelists?
Dr. Shetty, how you find the role of cardiac CT scan before the LA appendage closure procedure?
Okay.
Because TAVI has evolved from the TE and a 3D echo, a 3D TE based therapy to now a CT based thing completely. And it gives a fair idea regarding knowing the anatomy well in advance. What's your take on that?
Yeah, thank you, Dr. Abhishek. I think CT does have some role, but the role is not too much in this case, because most of the time patients while doing CT are dehydrated. They are outpatient procedure, 4 to 6 hours they are dehydrated. So unless it's a difficult case, you don't need a CT scan in this case, because the measurements you do will be different on table. T, on the other hand, has a big role here. So this procedure probably differs slightly from TAVI, in the sense TAVI, that anatomical, it's the iota, which is just like it's like a cylinder. The shape is fixed. You get a lot of information in TAVI, and most of us cannot do a TAVI without CT, but appendage closure, on the other hand, is possible without CT. It's helpful in difficult cases where people have failed and you want to be very sure. You could do a 3D model, but not in many other cases.
And I might cover a bit of that, Dr. Abhishek.
Yeah.
Dr. Shetty, fantastic. As you said, this is a teamwork. Without the help of either CT or TE, some imaging cardiologist is required to do this procedure as well. And therefore, that I think having a good relationship is very important. And for the growth of the program, as you said, you need to have a good partner. So how would you say that to start off a program, what are the barriers that in India that we are facing now to that we don't have too many programs?
Yes, thank you, Dr. Ramesh. This was the question I wanted to ask you. how to make an effective program, but yes, thank you for asking that. So I think the barrier, especially in India, apart from the cost, obviously, is being the physician reluctance. If I can boldly state so, it's been a physician reluctant because most cardiologists here, we don't divide ourselves into general and electrophysiology. It's more of a team of a cardiologist, and most of us do see around 8 to 10 AF cases. It's just common to see. So, but that also means that most of us have some patients who require this procedure. There would be patients who are on NOC and who have bled, patients on CKD, patient on CLD, thrombocytopenic. There are many patients who would need this procedure, but the physician now, at least, we started in December 2015. There were people who picked up early, like Dr. Hazra, who have done a lot of cases and who are very convinced. But the country, there are other doctors who need to be convinced more. But I'm sure, what I typically say is, indications you decide, but all of you definitely have patients who need this. At the same time, I would like to pass on the same question to Dr. Hazra. How does he convince his patients, and what is his experience?
Yeah, I know it's very difficult. Actually, who has killed or is still killing the LA closer in US? It is Mandrola, John Mandrola. He is totally against LA closer, but there are newer data like LO registry data presented this year in SEC 2021, and it shows that US registry about a large number of patients, 70,000, I think, that 70% reduction of ischemic stroke. So there are more and more data are coming. The previous data protected previous they could not show the death benefit convincingly. The Mandrola protested against the number of deaths reductions in the trial. Now we have more real world data that it does reduce ischemic stroke. There is no doubt that one-time therapy does prevent hemorrhagic stroke. In India, the problem is it's a preventive therapy. It's not like a TAVR Ramesh does and the patient gets pre-op dyspnea or heart failure next morning. And you never know whether patient will get a stroke or a no stroke, but he may die due to perforations or some complications during LA close. That is the fear and apprehension in many physicians' mind. And that's why either they don't refer this patient, they don't share the decision with the patient, they don't discuss that these therapies are available in India. And we are the people trying to convince the physician more and more by showing that it is as good as very safe procedure under imaging guidance, what Ramesh will be telling us, the ICE guidance or the CT scan guide. Coming back to CT scan algorithm is going to come, but CT scan is the best for post-operative follow-up of these patients for device-related thrombosis or other complications of the device. But in India, we still believe in T-guided measurements, what Ranjan has taught us. I learned from Ranjan, and we still believe that T is feasible in most of the cases where you cannot do the TE, we can go for CT scan. Now, there are sizing algorithms are also changing very fast. So coming back to Ramesh's questions and Ranjan's question, the price and more training, more discussion, more seminar. This is for the first time Ranjan has organized a seminar, but before there is no such attempt by any structural heart disease specialist like Ashok said. And Ramesh also is very, very much as a kind of help us in many aspects, but he has to do more for convincing Indian people.
Thank you, Dr. Hazra. One, I think I'll just ask this question to Professor Carsten. What has been the experience in Berlin or Germany? And then we'll go back to Dr. Ramesh for talk. And there are many questions, but we'll take it up one at a time. Dr. Carsten, what's been your experience in Europe?
In Europe, or in Germany, we have high numbers of implantations. but you still have because of lack of data. So if you compare the NOAC trials with the device trials, of course, device trials included only few patients. And that's why there is a lot of, how should I say, a reluctance to undergo the procedure. And so in general, the NOAC trials, they reduced mortality, they reduced stroke, but bleeding is another matter. And for these high-risk patients, we clearly see the indication, but even those patients, and you talked about it, are sometimes reluctant to accept the closure. But I think, especially with the Prague 17 trial, we are now at a phase, after Protect AF and Prevail, there was a long time with no randomized data. And now we have suddenly so many trials, including, I would say, almost 20,000 persons right now that are undertaken, that within not too long time, we will have a better understanding for the indications. And we will go even in low-risk patients. There's a Champion AF and the Catalyst trials with 3,000 people that go into not so high-risk patients for LA closure against drug therapy. So, and they are recruiting right now. So in 2 to 3 years, will, I guess, have a wider implication for LLA closure. And so we are doing a trial with 1,000 patients in Germany right now for high-risk patients with contraindication for long-term anticoagulation. And we are now at 600 patients are included. And so within 2 years, we will have the first randomized trial in this patient group that is missing. And that, I guess, will level the field for that indication that is still a to be, right?
Thank you, Dr. Carsten, for that wonderful comment. So, we'll
Dr. Ranjan, maybe we permitted us 2 points for discussion.
Ajay, yeah.
So, first of all, congratulations on a beautiful lecture. Yeah. Just 3 points if we have time for discussion, either now or later.
Definitely.
Number one is the type of anticoagulation that your patient will be prior.
Yes. Yeah.
Very often patients before they come are already on anticoagulation. And would you like to continue NOAC? Because I'll tell you our experience. We had in our initial experience with WATCHMAN, we did have an infusion. At that time, idarosumab, etc. were not available. And there was a little bit of an issue because the patient continued to leak. So now we routinely switch them to routine warfarin. Because in case you need to reverse, you can do it very rapidly if the patient is on warfarin. It is much cheaper and faster. It's just a practical point.
Yes.
Second thing, how much of protrusion into the LA would you permit your WATCHMAN device? I've seen the company IFU and the recommendations, but most of the time, I think the WATCHMAN kind of protrudes quite a little bit more.
Yes.
And how much would you accept?
Yes.
And lastly, the kind of anesthesia, because the kind of immobility that you require for WATCHMAN, sometimes the time between you put in the WATCHMAN access sheath and then you need to put in the delivery sheath inside. At that time, you need the sheaths to be deeply inside the LA, and you need the patient not to be moving much. And that time, a little deep breath or a cough could be, a little bit of a problem. And in case you do have a pericardiocentesis, what you do? What we do is we go ahead and quickly finish the procedure, because then you can actually limit further leaks. So I just thought some small points for discussion.
Yes. Thank you, Dr. Ajay. And I think most of it you have answered it already. So I just have to do. So I think the first step is to shift. Yes, I never do a knock. I agree with you completely. I may not even shift them to warfarin. I just stop the knock for 2 days, because most AF anyway, we don't breathe them for if it's a non-valvular AF, even if they're undergoing a dental extraction or some other procedure, we don't breathe them. So I typically stop the knocks and do a TE on table and just continue the procedure. The second one is how much protrusion. That's a very important, interesting question. The single thing which has changed why we are able to close LA in 98.5% versus 87% of in Protect AF is that we accept what we call as a shoulder, that is protrusion into LA. Now 50% is acceptable. So technically up to 160 millimeter is where the this up to 50%, 25% is very easy, but the shoulder up to 50% is now acceptable. The third trick what you told is anesthesia. In my center we do it under DexMed, because again one more person which I didn't tell is our cardiac anesthesia team. They have been really wonderful. So on DexMed they give us, it's not an intubation, it's a drug which is alpha 2 agonist. It's like clonidine basically, but it's analgesic. People do listen to you on this drug. I'm sure this is something which varies. I'm sure in Berlin also they do under more, not under GA, but under sedation, and many centers here we do. One trick which Dr. The worry, because your sheath is in, my advice, even if you're doing WATCHMAN, don't go too in, don't be pushing the left atrial appendage. You don't need to do that. You could still be at least 5 millimeter inside and start deploying your device, because anyway you're accepting a shoulder on the other side nowadays. So it's not needed to be, the problem comes because your sheath is now touching atrial tissue and pushing it away. You don't need to do that. That's what I've learned over the period, that you really don't need to be that in. You could leave them some space there so that little bit movement makes it safe. So
can I make a point here?
Yes.
For protrusions, now you have to understand the metrics of the WATCHMAN or WATCHMAN flex, the PTFE covered part. If your PTFE covered part is exposed, then there will be no benefit of WATCHMAN, and then it can propel as a melon seeding into the embolism chances very high.
Yes.
So you have to understand the PTFE covered, how much, you can go in. If you oversize, that will cause more protrusions, and your PTFE covered may not be occluding the LA appendage. Second, if you have this WATCHMAN-like device, if you protrude too much, and if you are contemplating ablations, doing ablations with too much protrusion of any LA closure device will be very difficult. It's much more forgiving to have WATCHMAN flex than you have a disc-based closure like you have ACP amulet. So ACP amulet ablations at the inferior surface are very, very difficult. You can do ablations on the superior surface of WATCHMAN and ACP very nicely, but it will be very, very difficult to do on the other surface. So too much of protrusions definitely can cause concomitant procedures and ablations, but you should not leave any gap behind. That is more dangerous for DRT, device-related thrombosis. Protrusion is much more forgiving if you have covered 2/3 of the PTFE membrane inside your LA appendage.
Thank you, Dr. Hazra. We'll go to Dr. Ramesh's talk. We are slightly running short, but we will continue to have this discussion. These are very important. Dr. Ramesh, over to you. And Dr. Ramesh doesn't need any introduction for anybody in India now. And personally, is a very close friend to me, and I thank him for accepting the invitation. Over to you, Dr. Ramesh. Yes.
Okay, now can you see my slides, Dr. Shetty?
Yeah, we can see Dr. Ramesh. Yeah, please go ahead.
And it's in the presenter mode.
Yes.
You're not seeing two slides, right? Okay.
No, we are seeing two slides, Dr. Ramesh. Yes.
Oh, okay.
Yes, now only one. Yes, now only one. Yes.
So thank you very much for having me, Dr. Ranjan and Dr. Carsten. A great pleasure to be with Dr. Hazra and Dr. Ajay, swamy, and Abhishek. So I probably will be talking mostly about WATCHMAN because that's the only device experience that I have. We have done about 500 or crossed 500 of these last month. Since 2016 when we started doing the WATCHMAN procedures. Now we mostly use WATCHMAN Flex. And as it has much better flexibility, control, and compatibility, And as you mentioned, that we do not have to go too deep into the left atrial appendage. We just started almost at the ostium of the left atrial appendage, and then gradually advance it after forming a ball with the WATCHMAN Flex device, which is much more forgiving in terms of complications. So, I mean, you know that, there are other devices such as Lambre, which is also now looking at in India as well as in the United States. It has been approved by, it is CE marked, and as well as Chinese FDA approved. And several other devices like Amplax. So still, we have participated in the Amulet trial. It is still not FDA approved yet, and we're still waiting for that as well. And we'll discuss about some of the trials at least discussion-wise. I don't have any slides on that. But so we are increasing the treatment patient population by using WATCHMAN, not only in people who are high bleeders, but enrolling them in clinical trials such as option trial, which we just closed with WATCHMAN, is ablation for atrial fibrillation, and post-ablation people can be randomized either to WATCHMAN device versus a NOAC. And the other one, as mentioned by Carsten, is a Catalyst with Amulet, and a Champion AF trial, which is with the WATCHMAN. Those are actually going to test NOACs versus WATCHMAN. So right now, we do all of our 500 people that we have done are all high bleeding risk patients. So coming to imaging modalities, we depend upon several things. You need to be very proficient on understanding TEE and fluoro. Obviously, we are all very good at it. And just a simple fluoro views are AP and RA Coral. That's what I use, RA Coral 2020 for the device deployment, and LA appendage or pacification with contrast. And but you can minimize the contrast with using a half and half contrast. And the TEE is the gold standard. You depend upon 4 standard views: 0, 45, 90, 135. And 3D reconstruction is great with TEE. And it requires, as we mentioned, about sedation analgesia or general anesthesia. And we'll talk about at our center. My experience has been that we have gone back and forth. We did TEE, and then we switched to ICE, and then now we went back to TEE because our anesthesiologists are so good, and they can intubate the patient, extubate the patient, and we discharge all our WATCHMAN patients on the same day. We do about 4 or 5 WATCHMANs in a day every Tuesday, and we still are able to send them home on the same day. So I don't see the advantage of whether it is anesthesia, general with intubation versus a MAC versus actually ICE with local sedation. Ultimately, the patient is going to go home in a few hours. What is the biggest deal? I don't have an answer for that yet. Obviously, it requires additional operator, but sometimes having an additional operator for TEE or even for anesthesia helps us in the sense that we can concentrate on what we need to be. One time, while doing a WATCHMAN procedure, as soon as even before we started the procedure, the transeptal cannula went into the SVC and we dragged it down. Patient became bradycardic. So I don't have to concentrate on the treatment of bradycardia. The anesthesiologist, obviously, they're very well trained. They take care of it. So it is a teamwork. Can I do all that? Yes, I can do all of that. I can stop and give treatment for bradycardia or check what is the cause of it. So, it does happen, and we have canceled them one time. My partner canceled my procedure because of severe bradycardia and put in a pacemaker first, whereas I did not. I just gave them some atropine and put him on AP, which the anesthesiologist did, and the patient was fine, and we proceeded with the procedure, and that transient bradycardia resolved on its own. CT is actually coming up quite a bit in our due to COVID, in fact, not because of any reasons. For TEE during COVID, we need to get a COVID test for every patient that's undergoing TEE. Now we are changing those rules, at least in our center in West Virginia. Whereas a CT, we depended upon that to plan, because you don't need to have a COVID test. It's much easier. Pre and post CT assessment of left atrial appendage has been done very a large amount. But then again, we detected that more device-related thrombosis were being reported by CT because our CT imagers did not know how to evaluate this WATCHMAN Flex device with more PET covering. And therefore, some of the skirts that are seen or a PET layer is reported as DRTs. And so we went back to using TE now in post-device assessment, but it can be used. And obviously, the advantage, no sedation, no anesthesia, highly detailed anatomy. You can actually find some small leaks to actually some complications. Yesterday we detected a fistula between the pulmonary vein and left atrial appendage on CT. So that is very rare, and probably it will be written up and reported, but you can see sometimes what we don't want to see as well. So the contrast is the most problematic in CT. We do not recommend, as Dr. Ranjan Shetty mentioned, that people who have dehydration and already they're coming in and we want to use contrast, having a pre-planning CT will definitely affect their kidneys, and we don't recommend that. TRUPLAN is something that is coming from WATCHMAN, Boston Scientific, and how to plan for this device, where to exactly do your transseptal puncture, to how should we deploy the left atrial appendage. Intracardiac echo, I'll show you a little bit about that. It is off-label, it is invasive, it can be performed without anesthesia. One of my partners has been very proficient in that. Limited views and far field imaging, and obviously cost versus time. I mean, that's what we have to think about. Cost of the device, which may not be reimbursed. It costs us actually extra $2,000 versus actually a TEE, and which might be reimbursed and by the insurance company. So I took off lots of slides because Dr. Ranjan Shetty mentioned a great, he showed how to use TE and imaging. And so it is important for pre-procedure, intra-procedure, 45-day check, and also a 2-month check if you want to further prolong it. What our practice has been, all our patients, whether they were on Coumadin, we continue Coumadin for 45 days, then switch to aspirin and Plavix as per the clinical trials, and for 6 months, and then DC Plavix and continue aspirin for lifelong. And if they are on NOAC, we continue NOAC for 45 days and then convert to aspirin and Plavix. If they are not on anything, we continue aspirin and Plavix for 6 months and then remove the Plavix from their medical regime. Appendage morphology can be well evaluated by TE or CT scanner. The different types of appendage morphology. Windsock is very good for us to do an implantation, whereas the chicken wing is also not bad, but broccoli and these types of are very shallow. Lot of shoulder will be hanging into the left atrium. So these are the ones which are probably not the best ones to treat. So 45-day follow-up TEE, again, 4 views. All we need to know is 0, 45, 90, 135. And look for stability, the shifting or uncovered lobes. Seal, which is new or increased peri-device leak, as Dr. Ranjan Shetty mentioned, we accept up to less than 5 millimeters, and the smaller the leak is better. Sometimes we try to attempt to close bigger leaks with ampullates or plugs, and you can do that as well if need be. So device-related thrombosis is best assessed, in my opinion, with the TEE rather than with the CT, unless your CT images are really very good about how to understand each device might be slightly different. And so you need to, WATCHMAN to WATCHMAN Flex. When we shifted from WATCHMAN to WATCHMAN Flex, our DRT rates went up from about maybe 2% to 20%, because they were reading that the material as a DRT, and so that is really problematic. So you need to understand how a CT can be done in how a CT looks in a patient with the Lambre, with WATCHMAN, or with the Amulet. So different devices, and so not one specific imaging is good for all the devices, and obviously assess for pericardial effusion as well. So device-related thrombosis, we have published this as well, and there's a gender difference between men and women, and so incidence is about 4% overall. the predictors of DRTs are permanent atrial fibrillation, prior TIA or stroke or vascular disease, and larger left atrial appendage diameter, low ejection fraction. Obviously, they are the ones who have higher chance of DRTs. And imaging is essential in people who have DRT. If they have a DRT at 45 days, continue the warfarin or NOAC for another 3 months and repeat another TEE. And if it is still there, continue. I would say continue for probably a year and repeat it again. Okay. So here is a 78-year-old CHATS VASC of 6 and a Has blood score of 4 and multiple GI bleeds, and the WATCHMAN was 2.5 was aborted due to the size of the appendage in the past. And so we sent this patient for a CT because we already attempted one time with the TE guided regular WATCHMAN. And so we looked at this patient, and on CT TRUPLAN, we said the average diameter came as at 31.4. And with the WATCHMAN Flex now that we thought maybe we can attempt this with the WATCHMAN Flex based on the TRUPLAN. That's how CT scan helped in this particular patient. And as you can see, area is 778 and the depth is actually 28.7 millimeters, which is good. So the same thing on the TE, when we looked at it, you can see on 0 degrees, ostium is 38.8. And it is varying so much between 0 to 135 degrees, as you can see, 25 all the way to 38 millimeters of osteo diameter. And then when it was performed with the WATCHMAN Flex, there was a gap on one of the views. You can see it in here. And 132, it did not appear bad. On 90 degrees, it appeared that there's a gap. And so a small tug test was done, and then after 10 seconds forward pressure, the gap actually became much less, and we felt that this patient could be let go. So looked at compressions, and position was remained very stable. As you can see, maybe there's a 2 millimeters to 4 millimeters shoulders on to the left atrial side. But there was a 20% compression in all the minimum of 20% compression in all the angles by TEE. So the post-deployment, actually, this is very good, and we had no issues with it. So we left it, and so this is how you can put the sizing on the CT and the TRUPLAN, and that we were able to do a successful WATCHMAN Flex large device 35 millimeters in this patient. And a follow-up, the patient did quite well, discharged the same day, and a 45 follow-up showed device well positioned and no leak, and he was able to come off his anticoagulation at 45 days. So in cardiac CT, the highly detailed assessment of left atrial appendage is possible. Morphology and the pathology delayed imaging will show that. If in doubt, TE is obviously the gold standard. And excellent pre-procedure planning for left atrial appendage closure. And I showed you one case of where a patient was tried with the WATCHMAN and aborted. Then we were able to complete it with the WATCHMAN Flex with the due to having that CT planning, and like a virtual valve, we now do a virtual WATCHMAN device. And whereas at 45 days, the CT replaced TE at 45 days. Maybe, we don't know. But the trials did not use CT in PROTECT, PREVAIL, or PINNACLE Flex trials, all the ones that we had so far. And so the data on CTs is still limited, and it is going to be probably looked at in more closely in the future. So right now, we were following patients with CTs, as I mentioned, but due to problems in COVID. But now with the COVID testing is not being required for at our center for TEEs, we are going back to TEE assessment. So as Dr. Ranjan Shetty showed one case, and maybe I'll show a couple of cases here. This is a patient who I had a terrible time getting a transseptal puncture. And how much I will see how bad I've been flexing it and trying to rotate it. Safe sept wire was advanced and had a lot of trouble. But finally, with the safe sept wire I was afraid of pulling it back because it kept coming back. So, but with the gentle tug on the safe sept wire while advancing the transseptal SL1, we were able to go ahead and do that easily. So once we are there, as I said, RAO caudal is the view. Advance your, the curved sheath and 14-French sheath and the pigtail. You take a picture through the pigtail. and this is very good. And TE showed a good compression and position. The pass criteria are met. And so then we did the tug test, and we let it go. And it was very quick and easy once we were able to do the transeptal puncture. That actually took 2 hours, and 15 minutes was the WATCHMAN deployment. So let's quickly look at ICE, whether ICE is going to talk about, we can talk about whether it is going to be replacing TEs in the future. What are the advantages and disadvantages? My partner, Dr. Al-Khuli, when he was here, we published a great deal of WATCHMANs on ICE, and ICE, as I said, is still invasive, moderate sedation. That's the greatest advantage, is that moderate sedation. What he used to do, for example, was that now we do 4 WATCHMANs in one room. My other partner, probably, we have too many people now, so other partner is doing PFOs, ASDs, or whatever VSDs that he was in a different room. So what he used to do is he used to have 4 WATCHMANs in one room, the other 3 or 4 PFOs in the other room. So he would be going from one room to the other room. So that's the only advantage. The only advantage is that if I want to do 8 cases in a day, I can do 8 cases and be happy about it. The patient viewpoint, it doesn't really matter what have we done, So that's why I think I'll take it with a grain of salt. If you really want to be trained in ICE, we definitely think it is possible to do it. And we do cases occasionally on ICE now as well, but not as much as previously, because there is a limited far-field imaging, limited 3D capabilities, lack of biplane imaging at the same time. And complication rates are comparable, but even if it is less than 0.5 with TEE and having even 1 to 2% complication from ICE, you can see whether it is acceptable. And cost is going to be the biggest limitation in the United States or in India. But the 2 basic ICE catheters, whether it is AccuNav or ViewFlex from Abbott, both can be used. And now 3D and 4D ICE catheters will be coming in. Philips is coming with the 3D ICE catheter as well. So initially, we were placing the ICE catheter in the right atrium was struggling, but now once we place the ICE catheter in the left atrium, it becomes actually much simpler. You just do one transeptal puncture, put 2 wires, just dilate the sheath and the transeptal puncture, and actually the ICE catheter, even without a wire, it just goes in easily without any problem. But if you have a problem, you can dilate it further and put the ICE catheter as well. So dilate the septum, track ICE catheter across the septum, following wire tracking to the left atrium. We use this somewhat similar to ProTrack wire, and we don't have to place it in the SVC or in the pulmonary veins actually. And so simplified imaging protocol with ICE in the left atrium, single transeptal puncture, 2 orthogonal views are a must. And you can look at this, it's called a modified pass, and position is only in 2 views. Anchoring and the size and seal are only possible in 2 views, which actually are not going to be the best. And you can see that there may be sometimes you might miss a small leak around it, as compared to 4 views in TE. And so if you are looking at so the 2 views, a mid left atrium and more like a 0 to 45 degrees, and from the LV and across the mitral valve, so that ICE catheter is bent a lot here, as you can see, and looking at up from below, and it's more like 90 to 150 degrees on the TE, and flip the catheter high in the left atrium, and extreme posterior tilt you have to give. It's scary sometimes for me as well, and advance across the mitral valve, and you can see that. So here is a deployment by my partners.
Good. Okay. I'm going to try to deploy here.
So once that is done, you can check the position and size, and both in ICE and by fluoroscopy. And again, LV high view in the device imaging position, and the mid LA views, And so this is you can put a color and look at any seal, and there is it appears to be a good seal over here.
Equivalent to a higher view. Okay. So let's just do a color, please, Melissa.
Okay, so and then you look at the anchoring both by tug test, and that you can actually see on the ice actually as well.
Here.
And the patient passed anchoring, and so then the device is released without any problems.
Pull this 135 maybe. Go ahead and measure the compression and the color sweep. So we're happy we meet the modified pass criteria for ice. Go ahead and release this. So this is the last view I'm going to give you to pull this 135 maybe. Go ahead and measure the compression and the color.
Okay, so then finally with ice, you can also do the check the effusion, and in both the views, and as we mentioned about left ventricular long axis and short axis, and once you check that there's no effusion, you can take everything home. So my take-home message is for imaging is the TEE is still the gold standard for WATCHMAN or any left atrial appendage devices. And ICE-guided left atrial appendage closure is increasing in few centers, and it's not widely accepted all over the country yet. And the CT use is increasing as well to assess both the pre and post-procedure planning, and maybe having an overlay of CT on your fluoroscopic imaging to know exactly where to do the transseptal puncture will help. Thank you very much.
Thank you, Dr. Ramesh, for a wonderful talk and beautiful explanation of the ice imaging were actually very beautiful there, and you have shown that it is possible to do. For long, people thought ice was very good for septal puncture, but unless you enter LA, the imaging is not good enough. And most people thought the CT is a must if you're using ice in the beginning, and you may have to do some angiographic views because you're still not fully confident of what ice can show, but you showed it very well, Dr. Ramesh.
Yeah. I recommend CT for ice actually. If you're going to do ice, you should do CT.
Yeah. So now we'll go to Professor Carsten's lecture, and then we'll take. There are many questions which have come. Then together, I think I'll pass on the question to both of you. Dr. Carsten is Chief Clinical Director, Head of Cardiac Arrest in University of Berlin. Over to you, Dr. Carsten, and then we'll have a discussion. Thank you, Dr. Ramesh. Yeah.
Just a moment. Okay. Can you see my slides?
Yes. Yes, Dr. Carsten. We are seeing your screen now. Yeah.
All right. Okay, it's coming on.
Yeah.
Okay. Thanks again for the invitation, and so it will get a little bit practical. I will present one case of large LAA that was possible to close with the lumbar device. So we change now from WATCHMAN or WATCHMAN FLX to lumbar. So this is a 73-year-old gentleman with permanent atrial fibrillation. He had 2 strokes, one while on a NOAC, and has peripheral artery disease. There are some thromboembolic events and arterial hypertension and diabetes, and that makes him a high-risk patient with a Charles-Watts score of 6.5, split of 3. And we spoke about that. Just a minute. That this is a patient, according to the guidelines, it's possible to close, but we don't have enough data. That's why it's to be advised. So we have different devices. So in Germany, basically, leading in market share is WATCHMAN now, only WATCHMAN FLX, basically, and the Amplacer Amulet, but lumbar is catching up and was introduced 4 years ago. This is a lumbar case. And why that is, I show you here. Lumbre has certain advantages against the other devices. And you see here typical characteristics in an expert consensus paper. This is really good if you are dealing with LAA, because it's a summary of all the procedures and devices. And what you can see here, and I wanted to point that out, that basically with all devices you can close LAAs from 11 to 32 millimeters. And there is no border given or no limit given for Lumbre, and we will come to that. So the characteristics, it's a disc type device. You have two parts, the disc and the umbrella, and it is really atraumatic. It has a double membrane design. There's one membrane, we will see that soon within the disc, and you have the proximal umbrella that has a membrane as well. So in theory, you have two membranes closing the LAA. The disc is doing the main job. Then you have, of course, a recessed hub with all devices for better endothelialization. And this umbrella is really interesting, and that's different to other devices. You have these hooks and barbs, and they are atraumatic, as you can see. So no sharp hooks, and that is should give a good safety profile. And another advantage compared to other devices is that you have really small sheet size, 8 to 10 French. We use 10 French in Germany, but there are smaller sizes for certain device sizes available. So it comes in two specifications: the standard specification, 16 to 36 millimeter umbrella, and the disc is 4 to 6 millimeter larger. That gives a great variety of sizes, and you have special configurations because, as we heard, the anatomy of the LAA is quite variable. So if you have multiple lobes with septums, then you use a special configuration with a small umbrella, and the cover is 12 to 14 millimeter larger. And the most important thing is that this is the only device that has special build-to-order options available. And we see now the LAA of our patient. It's a Windsor configuration. Here we did a CT for pre-procedural planning. We spoke about it. It's easier to plan the procedure. And if you look at it, then you clearly see this is a large LAA. So the landing zone basically is 38 millimeter by 29 millimeter, and the ostium is 46 by 35 millimeter. So I talked about it. You can close, and we saw the WATCHMAN case before, to 32 millimeters max, and this is much larger. So usually there are different options available. You could, use several devices to close this, but that gives leaks. And so we decided to basically do a build to order option and just, ask for a device with could fulfill these anatomical measurements. So we do it basically like you do it in India. So we puncture the right femoral vein under local anesthesia, but we want to have an invasive blood pressure monitoring in case something goes wrong. So we use the radial artery, not the femoral one, in order to prevent bleeding complications. We have the monitoring, and then we give propofol, and the TE physician, he is experienced in intensive care medicine, so he is basically doing the sedation. And then we give, as you mentioned, half dose of heparin before septal puncture and half dose afterwards with an aimed ACT of bigger than 250 seconds. We do the TEE on the table. It's better for the patient, so no TEE before. We did a CT here to exclude thrombi, but usually you do it on the table, as you see here. Big LAA, and then the transseptal puncture. We spoke about it in the X-plane, few B cable inferior and AP posterior. So here it's a little bit of bending of the needle before then it advances, and we are in the left atrium. So 3D TEE is a really a good method to measure ostomy landing zone. Here, these measurements are a little bit smaller than the ones in the CT, which has been described. We measure the LA pressure, should be larger than 10 once we are in the LA. Otherwise, we give fluids 500 or 1000 milliliter to adjust LA pressure for the measurements. So new imaging modality is 3D multiplane reconstruction TEE, where you really can go through the LAA in different planes to measure your landing zone and your ostium. So here we have the RO caudal view, and we do 2 views all the time and choose the best one afterwards. So here's the AO cranial view shown as well. And then as an interventionalist, we measure here as well. It's not 100% align all of the time, but you get the idea and double check your sizing. So then this is the custom built option. I can tell you it's a 40 by 52 millimeter Lambert device. I have big hands, and that's why I put a scalpel there. So this is a big device that now has to be assembled, which is pretty easy. Since you have so many options available, it doesn't come pre-assembled because you have to store all these devices. So you have the loader, then you have a wire, and you just put these together, as you can see here. And then you attach your device to the loader. That might be a little bit difficult, as you see. You have to be really careful not to damage the device. After 2 attempts, carefully I screw the device on the wire, and afterwards you put the device into the loader, and that should be airtight, of course. So you have to flush with saline, put it underwater, and then you can basically retrieve it into the loader. And then you are pretty much ready to go. Here shown again how big the LAA ostium is. It's almost as big as the mitral valve orifice, as you can appreciate here in the 3D TEE. And here we give you 2 views all the time. So we use X-plane and fluoroscopy for the introduction of the device. And the beauty with the Lambert device, as with FLX now and the AMOLED, is that you can basically freely move within the LAA to position your device. And this is atraumatic as long as you advance the device a little bit and the umbrella is developed. So here the same in the 3D MPR TEE. You see the device here with these asterisks all the time, and can basically really follow where you are within the LAA. And this is the device implantation. You see here, it's big and takes some time. And here, now you develop the disc. Here is the umbrella anchored within the LAA, and the disc then additionally seals the LAA ostium. And you can appreciate the membrane in the disc. That's the second membrane of the device. So then, of course, we do some tuck test. And if you have such a big device, you want to make sure that that is not embolizing. So therefore, this is quite a tuck test. And we can see that in a TEE as well. It's coming up here. Again, you can see the membrane, and you can see that the umbrella is really tight and in the LAA. Afterwards, of course, you look for leaks on the edges of the device, of course, and you don't see some here in the to the Doppler. Then we look that it is nicely aligned and that the LAA ostium is sealed by the device with a 3D TEE, and especially the mitral valve shouldn't be compromised by the device, as we see here. And then we release the device and look how it looks like. We are happy. Big device, big LAA. So here again, the implantation with 3D MPR imaging. Here is the device now. The umbrella is implanted already. And you will see here now the disc is developed and closing the LAA. And you see that simultaneously in different levels. Okay. At least then we check the position after a release. Here we have the circumflex, here we have the umbrella, and we have the disc that is sealing the ostium. Everything looks nice in the Doppler as well, without any leaks. And finally, the check, we don't have any pericardial effusion. I have to say that with all Lambert devices we implanted, we did not observe any effusion until now. So this is the post-interventional CT confirming the TEE imaging. So complete sealing of the LAA. And here is the 3D view where you really nicely can appreciate the device within the LAA. So imaging plays, a larger and larger role and makes you just more confident about what you are doing. And in the end, a few remarks about the results of the Lambert device. We have the first Chinese experience on the left side with 153 patients. We see a major complication rate of around 3%. So this is what we see with WATCHMAN and AMULET as well. And on the right side, the European CE trial with 60 patients, same results that are summarized here. So you have 100% success, implant success rate, and we spoke about that. That went up over the years, and the safety profile got better and better, and we are around 3% peri-interventional complications right now. So here, one other study comparing, that's a registry, so no really comparison, but describing the everyday use. And we see that lumbar is especially suitable for difficult anatomies, just because of the nature or characteristics of the device. It is more often used in challenging anatomies, like in this case I presented. So in summary, with the lumbar device, special and complex anatomies of the LAA can safely and successfully be occluded. In this case, the implantation of a 40 by 52 millimeter device was easily manageable using a 10 French delivery system without any complications. This is technically feasible to implant devices up until 42 to 52 millimeters. And the advantages of lumbar is the wide array of configurations, as well as build-to-order options, as I showed you. I think it's really an automatic anchoring of the umbrella within the LAA, which is the opposite in the Amplatzer device. So we saw some pericardial effusion with the hooks of the Amplatzer device. In comparison to other devices, we have a reduced delivery system diameter, 10 French in this case, and hypothetical advantage would be a dual sealing of the LAA by 2 membrane configurations. Presently ongoing studies, we have the LISA registry in Europe and China with now 480 patients included, will hopefully complement the positive data on efficacy and on safety of the device. So that's the end, and I thank you very much for your attention.
Thank you, Dr. Carsten, for an excellent presentation. I think this is the biggest LAA any one of us has seen, and you managed to close it well. And I think when we spoke in that time, you know, that you have any device in shelf, you're likely to close 98.5%. But if you have lamprey, I think it's going to be 100%. You know, you're likely to close more appendages with lamprey than any other. I was impressed with the fact that it did go in a 10 French sheet. That was the question I wanted to ask you. And it's been the most, and it's very easy to recapture. And this has also been our experience that, you know, the position, you can position it in the right. See, with most devices, we have what is called as landing zone, and we try to calculate that landing zone. But finally, the device lands where it wants to land. You know, it doesn't land on the landing zone which you have decided for the device, and you accept the position. But with lamprey and also to some extent with the amulet, we are able to exactly position the device where we want. Most other devices, they just take position. Thank you, Dr. Carsten, for that wonderful, you know, presentation. We do have some questions, and which I'll ask to everybody. I think the first question I'll ask to Dr. Ramesh, because he has a lot of experience in septal puncture. So there's a question which says that how exactly, you know, how do we size the, how do you determine the exact septal puncture position? And do we need to size the orifice, length of appendage before you do? Because you do a lot of transseptal, you know, intervention, Dr. Ramesh. So I would want you to take this, because how would you do for mitral clip and a mitral valve and also for LA?
Yeah, very good question, actually. I think for mitral clip, you need to be very posterior, high, superior, and but they're still in the fourth ovalis. But whereas for left atrial appendage, it is a little bit more anterior than posterior. You don't want to be too posterior for that, and also inferior. And as much as possible, be in the mid to anterior and inferior for LAA. That said, with the true planning and with the overlay of exactly with our CT images are able to give us exactly where we should do the transseptal puncture. So now we are trying to get that overlay of that on our fluoro imaging, so we know exactly where we need to be. So in addition to that, obviously we'll also depend upon TEE in real time. But the advantage of CT TruPlan is going to be great for determining the transseptal puncture. And if you really are struggling too much with the torquing, as you said, the counterclock is what we do for a left atrial appendage closure. If you are really struggling with the sheath a lot, it is worthwhile just withdrawing it, do a new transseptal puncture, start off fresh. because you are going to spend more time and cause more problems than actually doing a different puncture.
Yes, thank you, Dr. Ramesh. Dr. Ajay, I think, has one more. The next track is Dr. Ajay, and after that we could have a discussion. He's going to do one more presentation on Lambre, and then we'll have a discussion. Thank you, Dr. Ajay. Please start.
Thank you very much, Dr. Ranjan. My job has been made very, very simple by Professor Carsten, because we have pretty much discussed everything that we could possibly have discussed in with respect to the Lambre. However, I will show a short case. Is my slide visible?
Yes.
All right. So this is the story of a 75-year-old lady with intermittent AF and 2 TIAs and a transient hemiparesis about 12 weeks earlier. She'd been on NOAC for 18 months and had an episode of GI bleed, and she was counseled about an LA appendage occlusion, and she agreed. And after the initial counseling, as we've discussed, the patient walks into the hospital, so patient must walk out, and the standard steps were followed. This is the septal puncture under TE guidance, inferior and posterior, as has been shown. I have cut it short because all the steps have been discussed in detail. We'll just focus on 1 or 2 points for discussion. This is the delivery sheath 10 French, which is placed inside. After this, we've already discussed this, so I'm not going to go across. Then inferior and posterior puncture. This is the TE assessment, and this is done after the LA pressure measurement. Once we're finished with the puncture, after half heparinization, finish the septal puncture, complete the heparin, measure the LA pressure, make sure it's more than 10, and then do the measurement in 0, 35, 90, and 135. Look at the sizes at the ostium and 10 millimeters inside to decide on the size that we require. And then go ahead. This is the Lambre device that's been placed, and you can see that it was a fairly simple and easy compared to the complex cases which have been shown. But it does have certain specific points, because as you can see, this is how we look at device deployment. You just look at the circumflex as the place beyond which the umbrella must be deployed. There should be a little bit of tension between the umbrella and the disc, so that the umbrella is completely open, so the claws can actually catch the trabeculae or some part of the LA appendage. The seal is tested on the echo, and then the stability is confirmed by the tug test. That's what is done here. You can see that the device has been placed, and there's a little bit of tension between the device, between the umbrella and the disc, and there's absolutely no leak. This is what it looks like after it's been released, and there's no leak that we see on Cine and on TEE. This has already been shown, but there are 1 or 2 points which are worth looking at. This is the size matrix and has been spoken about. There are 2 basic designs, one in which the disc is about 12 millimeters larger, and one which is 12 to 14 millimeters larger than the umbrella as compared to the disc. This is the delivery system, which has basically 2 sheets and a 45 degrees and a double curve. Either one can be used depending on what one is comfortable with. Since we initially started our work with Dr. Saibalkar, we are kind of predisposed to the single curve, but we have started using the double curve when required as well. The nice thing about the Lambre is that there are multiple ways in which it actually seals and holds. So the umbrella has got both the design of the umbrella, which kinds of pushes out against the trabeculae and holds, and there are multiple 8 small hooks which engage into the LA walls and prevent or kind of hold it in place well. And the disc, which is under little tension, will then completely close the ostium or the mouth of the LA appendage. As has been shown, it is suitable for various anatomies, single lobe, multiple lobe as well, and one could choose the disc depending on the size matrix available. And as Professor Carsten has said, it is actually possible to design a particular device for a particular appendage in case required. Patient rejections are minimum. All 4 anatomies which are commonly seen can be used, and special anatomies can be looked at and focused for with the size matrix available as well. The umbrella is for a single lobe is 60 to 36, which is 4 to 6 millimeters larger than the umbrella with the cover. That's what we used in our case, and can be 12 to 14 millimeters larger in case it is a multilobular anatomy with all the various anatomies. It's also got a special point that it has a coated cover with a little faster endothelialization, and most of the time we just get away with a dual antiplatelets for 45 days for 6 weeks and then continue on a single antiplatelet. In summary, basically this is a non-valvular AF patient at risk of embolic stroke who cannot or will not take anticoagulation, performed at a center with expertise for structural heart disease and low risk for complications. LA appendage occlusion, as has been repeatedly emphasized, is teamwork. Every part of the team must know exactly what he's doing, and we all come together and work together. Ideally, I think we should have a registry for occlusion in data reporting, although it will be driven 60% by what Dr. Ranjan is doing and 40% by what Dr. Hazra is doing. But there are several other of us who has a little bit of information, and I think it's pretty, the time has come for us to actually push this therapy, because we have around 250 patients on follow-up with non-valvular AF. And I feel that if we could convince a few more patients, we'll probably be able to improve our safety record. Anticoagulation is definitely not the answer for all. We can't do a head-to-head, and still we are restricted to patients who cannot or will not take anticoagulation. But there does seem to be a subset of patients in whom even the anticoagulant, even if they do tolerate, it does not completely bring their risk down to where it can be. In summary, this is a design which is unique with an umbrella and a cover. It pretty much is suitable for all anatomies. We close the appendage with the use of the umbrella design plus the cover, and we ensure good fixation. So this is for just to emphasize how little we all know about what we do. And thank you for your attention.
Thank you, Dr. Ajay, and for such a wonderful presentation. And as usual, you're very lucid, very quick, and you gave us a lot of time back. We were actually falling short in the presentation. Now we are ahead. We have a lot of time for discussion. Please stay as long as possible. I know you have one more commitment, but stay with us as long as possible. And if you are here, I would ask you a lot. There are a lot of questions which have come now. Yes. So let me start with Dr. Carsten, because this question is, and then maybe Dr. Ajay, because this question is specific about lamprey. Actually, it's about if you have multiple lobes, how will you choose which lobe to put the device, and how much to oversize? What about the outer disc? And it's a very specific. Dr. Carsten, what's your opinion if you have probably it's multiple early lobes? Yeah.
So two things to be considered. So I would take the upper lobe all the time that is aligned with your sheet, not the lower one. And the oversizing is really forgivable with lumbar. The umbrella is really flexible. So usually you take 4 to 5 millimeters larger than you measure your lobe in diameter, and so the hooks, we saw that the hooks, they have radiolucent ends, and they should align with another marker on the device, and then you know that the umbrella is completely open. Yeah, and so basically you take your measurements, and then you I shouldn't say that, but I can say that because Professor Lam said that as well. So your umbrella size is not the most important. So the most important thing is the disc is sealing and that you have the pressure, because that's your main closure. Is the disc, and so you should be deep enough in your lobe. Umbrella size can be 4 to 7 millimeter oversized, and then the disc is retracting, and the disc should be 5 millimeter bigger than your ostium. That's really important because it's going in and then it's getting smaller. And one of the problems that can evolve in that situation is that your umbrella is not deep enough and the disc has no tension, and then you get leaks because the disc is not so flexible and it's just being there, and you have small leaks. So this is to consider for these really difficult or challenging anatomies. Just go in deep enough. The umbrella size is not the most important, but measure your disc size, and that should be oversized by 5 millimeters.
Thank you, Dr. Carsten. I think you summarized it very well. So in a device like this, where there are two ways of protection. I think it makes sense. Most of the time when we take ACP amulet, I think we are more worried about the lobule or the umbrella and not on the disc, because there the disc is just pure secondary protection. Your primary protection actually comes from the lobule. But when you talk about device like Lambre, it is the disc which is, it's a partially covered disc. It's probably more protective. And even if you have multiple lobe, the purpose of your umbrella is just to anchor the disc so that the disc sits right. So it's very well put. And most of the time, as you rightly pointed out, all these discs need to have a little traction. It should be like a pacifier, a kid which the kids can never throw out their pacifier for simple reason that more they hold it, the more it is held. So it's very important that it is like pacifier and this. So Dr. Ajay, I think before you leave, we should ask you a question. How would you, it's a very interesting, a very nice question in the sense, landing zone. How do you choose your landing zone for your devices? Dr. Ajay again has experience with 3 devices, so he will be the right person to tell this.
So the landing zones are actually different for all the 3 devices. As Professor Carsten has said, the Lambre's landing zone is the most forgiving because it just doesn't matter. You just need to size your disc in such a way that it is going to keep your, you need to size the umbrella in such a way that it keeps the disc under a little bit of pressure. So it will hold in place and the hooks have place for traction. Now the amulet is slightly different because you need an axis of the neck as well as the axis of the body of the LA appendage. And if you do not size the amulet perfectly and decide the landing zone, which is about more than 15 millimeters inside the ostium, and you do not get the perfect angle between them, if it is over constrained, the hooks actually don't get exposed and the device does not catch. So that's very important. And of the WATCHMAN, as we have discussed, the depth of the LA appendage is the single most important criteria about where we will put the WATCHMAN device. Rather than the landing zone, the sizing and the depth of the appendage are the 2 most important criteria as far as the WATCHMAN is concerned. Sometimes if you put the WATCHMAN in too deep, this is not so much with the Flex, but definitely with the WATCHMAN, the old WATCHMAN. If it is too deep, you end up with a leak because it doesn't open completely at the mouth because it's little constrained if one is too deep. And in that time, one can do a partial recapture and pull it back out so that you can come back and close the leak. So the landing zone concept is actually not so great as far as WATCHMAN is concerned. It's the sizing, which is, I feel, more important as far as the WATCHMAN is concerned. I hope that summarizes the concept.
Yes, very, very well, Dr. Ajay. Thank you for that answer. Dr. Hazra, there is a question. Is there any sign that we should watch out and device deployment? While doing, when should we abandon the procedure? That's the question, Dr. Hazra. What would be your answer for that?
I mean, when do we abandon the
procedure? You're doing a procedure. What are the things you are watching out, and when would you abandon
this procedure? Because the device size does not fit in. Because of the retroflex LA, very small LA, where your WATCHMAN cannot go, even the amulet cannot go, but your Lambre can fit almost 100% of a LA morphologies. And second, once you see a thrombus there, suddenly you saw thrombus there, certain device cannot be implanted. Like if it is a surprise, like non-organized thrombus, and it is in the body, you can do this Lambre and the amulet, or your SCP with the mouth ball appearance forming in the pulmonary vein, then pushing, walking in the LA. If it is a thrombus in the distal part of the LA appendage, like in the apex, then you can implant. But if you have a fresh thrombus, non-organized, you should walk out. You should not put WATCHMAN there, and you should give a 6 weeks or 6 months therapy of NOAC and warfarin. And third, you should not walk out if you produce perforations and you complete your job. And like if you have produced a tamponade due to your small perforations, I hope it is not sheath related, then finish your job, reverse your heparin, put a drain. And the 5th one will be if somebody develops hypotension and progressively deteriorating after putting you do not know exact cause, you should work out. I mean, you should relook at what is the exact etiology of hypertension. But having T on the board, you can, like the disadvantage of CT fusion imaging, you cannot have pericardial effusions in front of your eyes. Eyes can detect, T can detect the ongoing pericardial effusions. So if you have pericardial effusion, one person does pericardial drainage, other person put the LA closer and you walk out. There are special situations, but most of the time you can finish the procedure, but pre-planning is very important.
Yes. Thank you, Dr. Hazra. I think you summarized it very well. So if you find a fresh, imagine you find a clot while doing, because most of us now do T on table, we really don't. Unless I'm going to Proctor, I ask them to do 1 T just before and rule out a clot because I don't want to travel and come back. Otherwise, in our center, we typically do T on table, but before a puncture, even before femoral venous puncture. If you find a clot, I think as Dr. Hazra is highlighting, fresh clot, or you don't know the duration of clot, try to anticoagulate. Short-term anticoagulations are tolerated for most patients. We are worried about long-term. And after 4 to 6 weeks, then don't use WATCHMAN because you're going to be very deep. Best device will be lamprey because once you make that hook, it has a mesh, so chance of you embolizing anything is fine. But this has to be done after after at least 4 to 6 of anticoagulation. Not at the. It's okay to abandon in that. Now, there's one question for Dr. Ramesh. Which specific anatomy would you avoid for LA closure among all of them? Any specific anatomy would you avoid, or is it okay to do all? Yeah.
I mean, I think here in the United States, we have, as I said, only WATCHMAN is FDA approved. So sometimes it's a problem if it is too large or too small, and or some of the broccoli type of ones that you need to be careful when you start off, you don't pick one of them.
Yes.
Device embolization is very uncommon, but it can happen, and it has happened even in our center because of patients. Selection was not correct. So that said, I think Dr. Carsten showed that, and Dr. Ajay also showed that there's no problem with lamprey. And so that's the advantage of having multiple devices on the shelves. And I think soon we probably will be having trials comparing one to the other.
Yes. Thank you, Doctor. Dr. Carsten, what is any specific anatomy you would be worried? I'm sure you'll not abandon any, but does any anatomy worry you, Dr. Carsten?
Some chicken wing anatomies are not as well suited for ball type devices, just because physics just play a role. So there is there is a larger risk for embolization. I just wanted to add to the thrombi, of course, so there is a 6 weeks anticoagulation course mandatory in those patients before you undertake LAA closure. But we had some patients that had an intracerebral bleed, so you couldn't anticoagulate them, and they had huge thrombi in their LAAs. And in this regard, you could close it with a disc type device, depending on where the thrombi are, or if they are distally, then you could use FLX with a protection device, so that you make it safer. So this is one indication that's debated. So if you don't have an absolute contraindication, then you have to anticoagulate, because the risk, of course, might be higher. But we have a series of 10 patients now with an absolute contraindication. This is really seldom the case, but we could safely include these patients with a protection device. And I have to mention, so in the protection device, we found thrombi. So this is an additional safety layer you can use if you don't have any chance to anticoagulate those patients.
Thank you, Dr. Carson. What protection device did you use, Dr. Carson, for,
There was Boston Scientific. I don't know. Sentinel, of course, yeah.
Sentinel, the TAVI one, which was kept from the radial artery, yeah.
Right,
Yeah.
right. So it's
For
easy
bilateral. We probably don't have it in India, so we may have to do bifemoral usual carotid protection device, the filter or Spider X, yes, and then do it. Thank you
But
for
these are
that.
really exceptional, seldom cases, but you might encounter one, and then that would be, one method to proceed.
Yes, I think it's very important that the procedure which is meant for future prevention of stroke should not produce stroke when we do a procedure, because it's really a prophylactic therapy. So we do have to be very, very careful. So so that's one question. Yeah, Dr. Abhishek is around. Do you have any comment, or Dr. Abhishek, are you there? Yeah. Dr. Abhishek is, I think is left, or we'll get him back. So the next question is, I think, to Dr. Ramesh, because they have a huge series. Did you have compression of circumflex anywhere in your series during any of the LA, and what is the remedy? Yeah.
Luckily, I did not have it, and not that it's not possible, but as I said, the remedy would be to stent it. We have seen similar compressions of extrinsic compressions of circumflex artery during robotic mitral valve repairs, either by some staple or suture at times. And so luckily, we were able to break the suture once. The second one was not able to break it, so the patient had to go back for redo surgery. So with the extrinsic compression of a nitinol frame, that I think you definitely will be able to make it relieve that compression by a stent procedure itself.
Yes. Thank you.
And the worst complication that, as I said, was a AV fistula. A fistula between the pulmonary vein and the left atrial appendage.
That case, did you close it with the LA, Dr. Ramesh? Because closing with LA would actually close the fistula.
No. Yeah, actually, this happened after the WATCHMAN device.
After the WATCHMAN.
We created a fistula.
You created. Yes. Dr. Abhishek is joined us. Dr. Abhishek, any comments or any this one about you could ask any of us, or yeah. Dr. Abhishek, are you there? Okay. I think
I'm here.
Yeah. Any comments or any questions?
The kind of. Yeah, I think it was a very elaborate and fantastic detailing about the therapy itself and different type of devices. And I think, but what I personally foresee is that if you are pros with most of the devices, you can close all the appendages of now. But I personally feel, might be because of my training from Copenhagen, that is going to play a more bigger role in this therapy in future. Because we typically used to hydrate the patient with a saline before we used to go, since the more and more devices are being available to us.
Thank you, Dr. Abhishek. I think you must have seen a lot of amulet being used in Copenhagen, right? That was the
plenty.
Yes. Thank you. Yes. So I think there's one more question. Yeah. What about Dr. Carsten? Have you seen any circumflex compression? Fortunately, I have not seen any. So have you seen any circumflex compression?
To be honest, no. But yesterday I was introduced to one that happened in Germany. And I know there's one case report out with the WATCHMAN and an RC exclusion. I thought it wouldn't be possible. But in this case I saw yesterday, the patient had an LAA isolation in January and had an implantation 6 weeks later, and now 2 weeks ago he was diagnosed with an RCX occlusion. Was a young patient, so coronaries otherwise were unremarkable. So either it was the LAA isolation procedure or it was the WATCHMAN implantation. But so until yesterday I didn't know that would be possible, but then I saw one case report. So it's really seldom, if at all.
Thank you. This. Dr. Hazra, what's your time gap between TE? How many TEs do you do on follow-up? And, that's the question here.
Never do. 0%. To be very honest, I don't want to be hypocritic here. The problem of convincing these people for another tea is very difficult, number one. And number two, what do you do? I mean, these are passing kind of weather. I would say like a winter and summer. If you have DRT, this DRT incidence 1.3% to 3% or 4% has come down with WATCHMAN Flex and more understanding of the LA appendages, the precise positioning. And if you have any doubt, like if you have found one of them, it does not mean that it will translate into strokes. So these DRTs may be a kind of illusion sometimes. And there is a study recently published by Nakamura from Japan, and he has introduced this endoscope, an endoscope in the appendage. Once they found that there are thrombus on the CT scan, but it could be illusionary because of the pin, because of uneven, lumpy, bumpy endothelializations. The PTAP cupboard can be misinterpreted as DRT. There may be multiple layers of endothelials in one place. One place may not be having them. So there are so many varieties, but that does not translate into strokes. The real strokes on DRT is less than 1%. And these strokes are smaller stroke, and ultimately you cannot take out the device. If it is a large thrombus, you must look out for a COVID-like situation in India nowadays, and you must look for thrombophilia. So those things are very rare once you have a pre-planning. So practically, I don't do TE, but research purpose is very important. But if you have a breakthrough stroke, I always look for another TE. Over to you.
Thank you, Dr. Hazra. I think breakthroughs, if you look at that registry, 1.8% did have breakthrough stroke on the device. And fortunately, the breakthrough strokes were smaller because now the appendage is gone. So even if you have a stroke, breakthrough stroke, it's smaller. The outcome of those strokes were better. But there are small percentage of patients, it's typically around 4%, that some device-related thrombus is seen, and probably they might require a NOAC and a lower dose to overcome. I'm sure that's the experience with all our experts. Dr.